welcome, and thank you very much for joining us today. My name is Rob Hawes, and it's my great pleasure to be the moderator for today's discussion. The goal of today's multidisciplinary discussion is to explore an important study that evaluated the role of AI in endoscopic ultrasound in the detection of pancreatic cancer. The study was recently published, just published this week, in the journal Endoscopy. And so to discuss the role of AI in endoscopic ultrasound and pancreatic cancer, we've assembled an expert panel to facilitate this discussion. On my right is Dr. Shyam Veeradarajulu. He's president of the Orlando Health Digestive Health Institute, and he was the original and senior author for this paper. To my right is Dr. Ji-Young Bang, who is head of clinical research for the Digestive Health Institute at Orlando Health and is the first author on this paper. Also, I'm joined by Adrian Saftoiu, who is an endoscopist, a good friend, and an expert in AI. And he's traveled all the way from Bucharest, Romania, where he is a professor at the Elias Emergency University Hospital in Bucharest, to lend his expertise to this discussion. Finally, I'm joined by Dr. Pablo Arnolletti, who is an oncologic surgeon with the Orlando Health Cancer Institute and an expert in pancreatic cancer. So I think I'll start with you, Shyam. Tell us what prompted you to conceive of this project and what you hope will be the implementation of this study.
When I did my training in endoscopy, I struggled the most with endoscopic ultrasound. I could see things with endoscopy quite clearly, but then this was all ultrasound images, and a small movement with the endoscope will change the imaging. And I also particularly I found any evaluation of the pancreas difficult. I struggled to find the organ. I thought identifying lesions was challenging, particularly if they are in some corner towards the tail or the uncinate, and detection of small masses was challenging. And the clinical implications of missing something was far too great. So at least for me, it took me about 1,000 procedures when I went to UAB to be very proficient with endoscopic ultrasound. So always I had an idea that we need to simplify this technique so that everybody else and the future generations will have the same outcome as an expert. And one day I was just reading a journal as I was flying somewhere, and I saw this paper published in a journal called Plus One. It came from Romania, and the senior author was Adrian Saftoiu, and he had described using artificial intelligence for evaluating pancreatic tumors. And this was done in a more like a lab setting, and he was giving his pilot data. So as soon as I landed, I think in Chicago, I emailed him and I asked him, listen, can we work together? We are very interested in this project because we are the largest EUS center in the Western world. This is something we want to take a lead on, and can we bring this to patient care? And he promptly responded, telling, "Listen, I just done 50 patients. It's a preliminary report. It's going to take a long time to get there, but in principle, we are committed to this project." So once I got his commitment, things always happen. You need money. So I went to Orlando Health strategy team, and I told them why this was important. And surprisingly, they were very kind enough. On the same day, they told me, all right, we're going to fund this project for you. You can work together with your colleagues in Romania and get moving. And then we recorded maybe about 300 to 500 real time procedures of the pancreas and endoscopic ultrasound, sent it to Adrian, and he worked on those videos to test, to create a AI software called the PANCRAIEUS software. And then he gave it to us, and he told us, try this. And then we got an IRB approval for preliminary testing, and here we are.
Oh, fantastic. So a very dedicated effort to getting this up and going and implemented. So with that, I'll ask Dr. Bang, tell us about the study design, and then also briefly tell us about the results of this study.
Absolutely. So we conducted a comparative prospective study. We assessed 308 patients who had been referred to us with suspected pancreatic lesions, either cysts or mass lesions, and also those with who were referred to us for pancreatic cancer screening. All those patients underwent endoscopic ultrasound, and we had 2 expert endosonographers who were both blinded to each other's methods. So we compared AI-EUS with conventional EUS. Every patient underwent examination using both conventional and AI-EUS. And what we wanted to do was to compare the detection rate of pancreatic lesions between AI-EUS and conventional EUS. So what we ended up analyzing or evaluating was we had 105 patients with pancreatic mass lesions, 104 patients with pancreatic cysts, and 99 patients with normal pancreas. And what we found was that the detection rate of AI-EUS was not significantly different to conventional EUS, with a detection rate of 97.1%. For pancreatic cysts, we did find that there was a significant difference between AI-EUS and conventional EUS, with a detection rate of 92.3% for AI-EUS compared to conventional EUS. And the reason was because we had patients with small pancreatic lesions who were not able to be detected on AI-EUS, primarily because for detection of pancreatic cyst lesions, the software is still in development and it is not trained to detect such small pancreatic cyst lesions.
Yeah. So this is always an issue, isn't it, with the development of new technology. You have to step in and test it at some point, but it's with the understanding that obviously it will evolve and get better. So with that, Adrian, I'll ask you, you're the developer of this AI software with a catchy name of AI-EUS, so that's great. Tell us more about how you developed this software and the process that was undertaken to test it in real time. And then tell us after that about, as you see the evolution of this technology going forward.
So basically, we initially assembled a small team. So we started with a very simple but an ambitious goal. So we wanted to bring artificial intelligence in real time for pancreatic endoscopic ultrasound examinations. So in order to do that, we started with hundreds of movies initially, exclusively from the team here, so from the Digestive Health Institute. We took the movies, we analyzed them, we carefully selected them, and all the movies were containing either normal pancreas, pancreatic cyst lesions, and also solid pancreatic masses. Then after selecting the movies, of course they were anonymized initially, and then we took thousands of frames out of those movies, and each frame was individually annotated by expert endosonographers. So basically then we trained a convolutional neural network model based on those annotated images, and the model worked in real time. We initially did an internal testing on new patients, and then we were bringing a system here to Orlando. So it was clinically validated, internally validated here, based on a prospective set of patients of over 300 patients. And Dr. Bangdal already explained the results. The team here used 2 observers, which were completely blinded. So one was doing conventional EUS, the other one was doing AI-enhanced EUS, and the results were quite similar. So we got almost the same accuracy, and the system was even able to depict really small lesions. In terms of the future, I think there are a lot of exciting things ongoing in the AI field. So we envision most probably a multicentric trial with several centers with various levels of expertise of the endosonographers, not only experts, but also doctors in training, because a system like this might improve the learning, might shorten the learning curve and improve the results. The second thing would be to look and try to predict the pathology behind each solid mass. So we could add complementary techniques like contrast or elastography, or even based on the grayscale, at one point we can predict the pathology if it's a pancreatic ductal adenocarcinoma or a neuroendocrine tumor or an inflammatory lesion. And last but not the least, I think these AI systems should probably be embedded in the hospital reports together with cross-sectional imaging, and they will bring, let's say, a normalization of the procedures regardless of the expertise of individual doctors. So I think that the future looks very bright for development.
Is the future on the horizon, or is the future way on the horizon?
I think it's more the present, because there is a lot of AI into ultrasound systems, also in endoscopy systems, but there was almost nothing on endoscopic ultrasound. So this is, let's say, a small step forward, but the technology will certainly improve very fast.
So good. We look forward to multi-center studies then coming on the future. So Pablo, I'll go to you now. You're the sort of the end user. You're the one that ends up seeing these patients with pancreatic cancer, hopefully maybe detected at an earlier stage, et cetera. But tell us from your perspective, from the surgical perspective, what impact this kind of technology and adding AI to EUS might do for your practice.
So as clinicians, we face challenges, and particularly in the populations at high risk for pancreatic cancer, patients with genetic mutations that predispose to pancreatic cancer, where it is difficult or impossible to have an early detection. And we rely on cross-sectional imaging for the most part, but oftentimes the interval and the sensitivity of those studies is suboptimal. So this could certainly improve as another important tool to improve the screening of the population at risk. As stated, it also depends on the clinical context. And in a patient at average risk with an incidentally found small tumor, it may be debated whether tissue is available or not. What do we do with the information? Mm-hmm. Anatomic location is also important. A small tumor in the pancreatic head is not the same as a small, tiny tumor in the body or the tail. For us as surgeons, it may offer challenges to locate that tumor intraoperatively if it's very small and can only be seen perhaps with intraoperative ultrasound, but maybe not. We've worked together before in placing fiducials, particularly for left-sided resections, where it would make a difference where to transect the pancreas in a lesion that cannot be seen, that we know is there. But certainly this is a valuable tool to incorporate to the context of the clinic of a patient, particularly as we bring on more and more molecular profiling in patients at risk, where we still struggle, and sometimes we face the scenario where, looking back at the cross-sectional image, there was a subtle change or a slight duct dilatation, or there was something that may have hinted that there was a tumor there, but we can only tell that in retrospect. And we see those patients regularly, and I think this is an important tool to help hopefully identify those patients at an earlier stage, but also, as stated, to level the playing field for operators that may not be as experienced, where we can then rely and have the support and artificial intelligence that brings a background of thousands of patients that were studied before, and that can make that information more significant.
I think it's an important point. Obviously, early detection is a key in cancer treatment and optimizing outcomes. But EUS is a greatly expanding field. Many people are becoming involved with EUS, and very few people will have the experience of Dr. Veridara-Julu in terms of the number of procedures. So I think that if we can have tools that will help people with less experience to detect these early lesions, this should have a good clinical impact. So Shyam, I'll give you the last word. You're always a pragmatist, and you look at things very objectively, but we know that maybe there's a multi-center study on the horizon, but give us a perspective about how you feel, how quickly or how soon you feel that AI will be incorporated into EUS and in routine clinical practice?
I think the initial step always looks very promising. You know, you have a new technology, you have tried it, it works, the data looks promising. Now, taking it from here and integrating in routine clinical practice is a difficult challenge. It's a long journey. We used one particular type of echo endoscope. We used the PDAC system to develop the software. It has not been tested and so forth in other manufacturers. There are new scope manufacturers in Asia particularly. So you have to create a tool that does not just work with one echo endoscope. We have to make sure it works with all echo endoscopes and all processes. That will require efforts from more than one institution. We are very fortunate at Orlando Health DHI to have 3 different type of echo endoscopes and processes, but it is just 4 or 5 examiners. So we have to include more centers. We have to include different kinds of processes, more varied pancreatic pathology, and even in the pancreas, we need to further advance this technology to say, if you have done a complete examination of the pancreas. Right now, we're just examining a pancreas in a particular region and finding a mass, but we need a tool that will tell us, yes, you've done a complete examination of the pancreas, you've identified these things. In this study, we had clinical correlation between a mass and a cyst. We need to take it one step higher to say what is a lymphoma, a neuroendocrine tumor, a solid cystic tumor, a pancreatic cancer, and so forth. And for all of that, you need tissue acquisition with correlation. So we are talking about hundreds of thousands of patients. We do about 4,500 EUS a year. For this technology to get into prime time, my take is you're going to require about 500,000 patients or 1 million patients with pathological correlation. So it's going to take a lot of effort from our discipline. I think one of the beauty of endoscopic ultrasound, you are the person who really taught us how to do endoscopic ultrasound, is that there's a motivation. It's a highly intelligent group. Companies, for some reason, are very interested in this technology. I'm glad that we wrote this seminal paper, taking a technology in the lab, doing it real time in humans, and provide the first manuscript. It is my hope that the subsequent generations will take it from here and reach it to the end point before my career would sunset.
So on behalf of Orlando Health, I want to thank Dr. Bang, Dr. Safatiou, Dr. Arnoletti, and Dr. Veradero-Julu for a stimulating and great discussion. And I think we look forward to the promise of AI improving EUS and the detection of pancreatic cancer. So thank you all very, very much. So I think it was a great discussion. I think that for me, AI is now permeating all aspects of our lives. But unfortunately, we're given this 30,000-foot flowery view that AI can change the world, and there's very few actual practical applications that we can sort of get our arms around or our minds around. So I think one aspect that I'm particularly happy about is that we now have a practical study, a study that utilizes AI, has proven that AI can be of practical importance, and now we can move forward to further development of this technology. So for that, I congratulate this group.